and those seeds stay there. And the results of this seed implant is very good, 80–90% of time, no problem, and they do the job. The third and the most advanced technology, which we call it high dose rate brachytherapy, started about 5–6 years ago. We did it in Flint 5–6 years ago, and though this technology is more tuning of the seed. Why is that? What happened in those technology, we put catheters into the prostate under anesthesia. These catheters stay in the patient. They are through a template, and this template is locked and stitched to the patient with 4 stitches. Patient move to radiation facility by the ambulance, and the CAT scan is done. Exactly, you know where are those tiny tubes in the prostate. They are between 8 to 16 tubes, depending on the size of the prostate. At that point, dosimetry or computer-aided dosimetry is done to tell us exactly how many seconds the radiation need to be in each tube. These tubes are hooked to a very special machine where very high activity source travel in those tubes, tube 1, tube 2, tube 3, and so on. The whole thing takes few minutes, and it deposits good dose of radiation to the prostate, everything under vision. In case of the seed could move, and the radiation is given over months and months. This is the radiation is given momentarily over few seconds. The full dose of radiation, that's what we call it high dose rate. The rate is very high, and the dose is given in few minutes. That's it. The whole dose is done. So I'm not worrying about the prostate swell later on, and the seeds will shift a little bit here and there, because I do the CAT scan, and in the same moment it's hooked to the machine and they give radiation right away. So I'm not worrying about 2 months from now or 2 weeks from now. There is a nodule and the prostate swell, and those catheters are far apart, because I just treat, then I take those catheters, patient go home. This is the most advanced way. The British did a randomized trial, and they showed superiority of high dose rate brachytherapy, and big data from this randomized trial. I should let you know that the other two is still good. If patient not like to have needles, the IMRT, intensity modulation radiation from outside, is excellent. If the patient does not want to have the seed because they have kids at home, and he would have little bit of activity and doesn't want to put the kid in his lab, and he's worried about the seeds might shift here and there, then the third option is a very good option on putting those catheters into the prostate and deposit radiation over few minutes. We take catheter out, end of discussion, and patient go home. Many protocols, some of those patients need to have those catheters given the treatment twice or 3 times or 4 times, depending on the scenario. So those patients with low risk either go for full course of radiation therapy, 8 weeks, 5 times a week, few minutes every day, or seed implant, or high dose rate after loading brachytherapy, putting tubes, lock those tubes into a special machine, radioactive source travel in those tubes, give radiation over few minutes, very good dose, desired dose of radiation, tubes taken out, patient go home. If the patient intermediate risk, then in addition, either they go for 8 weeks of radiation or 5 weeks of radiation plus either seed implant or high dose rate as a boost to the prostate. Those patients with intermediate risk. High risk is the same as intermediate risk, and hormonal therapy will be decided on individual patient, but for intermediate and high risk, the benefit is great for hormonal therapy. For low risk patient, there is some benefit, and you need to look at 3 things: the size and the place of the prostate cancer, the PSA, and how the location of the cancer in relation to the prostate. For example, if the cancer touches the capsule, if the cancer come to the seminal vesicle, and so on. So after patient treated with one of those options, then they need to be followed for PSA, prostatic specific antigen, to make sure that the cancer is gone, reflected by decrease in the PSA, and that could take up to 6 months and sometimes more. And you see those patients, the PSA keep going down to 1, less than 1, 0.1 or 0.2, and those patients need to be monitored and make sure the PSA does not come increased. When the PSA increased, not necessarily it is cancer. Sometimes it's just sometimes from the radiation to the prostate there is a peak of increase in the PSA, but if you repeat the PSA a few months later, it will come down, and those values will come down, and it will be very close to 0. Those patients need to be monitored, and we will show the success of this procedure, and those are highly successful. The cure rate is very high and is a good option for those patients desire to have radiation. If the patient desire to have a watchful waiting, provided they fit the criteria, that's a good option. If they like to go for surgery, that's also a good option. The main advantage of radiation is preservation of the function of the organ, and you have more chance to keep potency and a very small chance of having any urinary problem. But again, it is a team approach, and the patient, urologist, radiation oncologist, primary care physician need to discuss your case. Next time we'll focus on a different cancer topic, and good evening.